Welcome, everyone, to today's webinar. I am Brian Zimmerman, an Associate Vice President with Becker's, and I have the pleasure of serving as moderator for this discussion. Today, we're diving into a topic that sits at the intersection of surgical precision and patient safety, intraoperative neuromonitoring, and complex spine surgery. Before we start, just a few technical comments. You can submit any question you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you have trouble with your audio or visual, try refreshing your browser. You can also submit any technical questions into the Q&A box. We do have folks on the back end who can help out with that. I also want to thank SpecialtyCare for sponsoring this webinar. Before we get into the conversation, I'm going to tap on each of our speakers here to introduce themselves by sharing a few pertinent details about their background and the work they're doing today. Dr. Zaidi Hassan, let's begin with you. Can you share just a few details about your professional journey and the work you're doing now?
Yeah, absolutely. So I'm a neurosurgeon at Mass General Brigham. I do primarily complex revision spine surgery. I'm the director of the Adult Deformity Center here. So I do a lot of large revision fusions. Mitali and Matthew's been with me in the middle of the night, doing these difficult cases. I really got interested in these type of cases because of all the fancy technology that we use to be able to help patients, from where I started, training as a medical student at Hopkins. The way that we do neurosurgery then, when I started my journey in 2005 to now, is completely changed, and it's primarily driven by all the technological advances, including, the excellent neuromonitoring that has, in my opinion, changed the game and making surgery more reliable and safer over the last couple of decades.
Yeah, excited to just hear more get some more details about how you've seen that sort of evolve as we move through the conversation here. Mitali, go ahead. In addition to helping Dr. Zaidi late at night, what else are you up to?
Hi, my name is Mitali Bose. I am a principal surgical neurophysiologist and a clinical training leader with 17 plus years of progressive responsibility in advanced intraoperative neurophysiological monitoring. I'm basically a cranie specialist, but I always also do spines and scoliosis. I have a lot of respect for deformity surgery, and I really enjoy scoliosis cases, monitoring scoliosis cases, as well as anything complex you throw at me, I can do it. There is nothing that I cannot help you with. That being said, I have trained most of our team members also to be at the same level, and we are an excellent team in Boston, and we have been helping the surgeons in Boston area for a very long time. Dr. Hedequist and I have grown old together for 17 years. So, there's been a long relationship with the surgeons here in this area with me.
Excellent. Thank you for being here, Mitali. And Dr. Hedequist, Daniel, I have to turn it to you next. So go ahead and intro yourself.
Thanks, Brian. My name's Dan Hedquist. I'm a spine surgeon at Children's Hospital in Boston. I'm the chief of spine surgery there. I've been there for about 25 years. I do mostly spine deformity, anywhere from cervical deformity all the way down to, lumbo-pelvic cases. I've been lucky enough to be here 25 years, so I've lived through the evolution of neuromonitoring all the way from, sensory evoked potentials and wake-up tests all the way to really complex monitoring that we do today. So I'm looking forward to discussions and hearing how things are going with everybody.
Yeah, looking forward to pulling from that expertise and experience as well. Matthew, let's meet you.
Sure. Hi, everyone. My name is Matt Kozlowski. I've been working for SpecialtyCare for a little over 14 years. Had a variety of different positions in the company, working as a clinical manager as well as an area manager in the New England area. Recently moved into a new role as the Director of Clinical Performance and Innovation, focusing primarily on quality initiatives and how to drive clinical quality throughout the company, as well as focusing on newer techniques and ways to improve our monitoring as a whole. I've had the pleasure of working with both of these surgeons for quite some time, and it's just been a pleasure. I'm so happy to have them here.
Excellent. Great to have you as well, Matt. Dr. Doria, let's move to you now. I want to hear more about you, and also, I'm sure folks can infer quite a bit from in terms of what specialty care does from Matali and Matt's comments. But just for folks out there listening who might not be as familiar, can you really get into some of those details about specialty care in specifically the role you're playing in the operating room, just to set the stage a little clearer for folks, Dr. Doria.
Sure. Thanks, Brian. So I'm Joe Doria. I am a neurologist, subspecializing in clinical neurophysiology. I joined the specialty care team in 2022, and I've been serving as the medical director since 2024. Prior to joining specialty care, I was in an academic hospital setting, and I was treating epilepsy patients as well as all our in-house IONM. A little bit about specialty care. Specialty care, we are one of the leaders in intraoperative monitoring as well as neurodiagnostics. 2025, we did cover 130,000 cases, intraoperative monitoring cases, across the United States in about 750 hospitals. So pretty robust team. Our roster currently, as far as what our team is made of, we do have 37 oversight neurologists. And in the OR, we have close to, I think, 700 surgical neurophysiologists or our techs out in the OR helping support all these cases. So really great to be here, great to chat with the group, and looking forward to discussion.
Yeah, excellent. And maybe even doing some more context setting for us, Dr. Doria. Can you share for perhaps a surgeon or hospital administrator right now who might be newer to this space, why is neuromonitoring considered essential in spine surgery today? What's the core clinical case for it, just to set that baseline for folks watching?
So the core clinical case, I mean, we're getting more and more as far as diversity in cases. There's all different types. We do track internally the number of cases we do, the types of cases we do. About 78% of our volume right now is spine cases, with the largest making up probably extradural lumbar cases, and the remaining 22% of our cases is mostly head and neck. We monitor all these cases. When you think about intraoperative monitoring and what exactly is it, I like to think about it as like an early warning system. You know, the main purpose of intraoperative monitoring is to detect any signal changes as quick as possible and provide real-time feedback to alert surgeons of any potential neuronal injury or potential deficits that may be pending. And the real goal is to either prevent, stop, or reverse any of these changes as quick as possible. So that's the ultimate goal of intraoperative monitoring.
Prevent, stop, or reverse any of these changes as they're coming up. Appreciate you setting the stage there, Dr. Doria. Let's zoom in here and get sort of the pediatric spine perspective. So, Dr. Hedquist, beginning with you to get a lay of the land here, I guess what are the most common pediatric spine cases where this type of monitoring is not just helpful but crucial to the surgical plan? What would you say there?
Well, to start with, at Children's here, and I think nationally in most places, monitoring is really a standard of care. So almost 100% of children undergoing any spine operation are going to undergo neurologic monitoring. The majority of those are motor evoked potentials and sensory evoked potentials with triggered ENG. There's some small amount of kids that won't undergo those, all three modalities, but as a general, I think it's a standard of care. Obviously, the most common thing we operate on children is for scoliosis. So the goal of scoliosis is to straighten the spine as much as you can with a good balance result, but it's always neuroprotection, right? And so whether you're a high-risk spinal cord or relatively lower risk, the goal of anything foremost is going to be a neuroprotection of the spinal cord.
Excellent. And so pediatric patients can present some distinct physiological and anatomical challenges, certainly compared to the adult space. So I guess how do those differences affect how you're using this tool in the OR? What's different about using this in the pediatric space?
I don't do many adults, but from a pediatric space, I don't know that there's that much difference. We're really our standard of care is going to be sensor evoked potential monitoring, motor evoked potential monitoring. I think the difference maybe between us and Dr. Zaidi can talk a little bit about is we don't have as many cases where we have to worry about lumbar roots or root injuries. When you're early monitoring, you're looking at things as cord injuries or root injuries, or monitoring the cord or monitoring the roots. So most pediatric deformity, other than I'd say spondylolisthesis, is a general cord-based imaging, cord-based monitoring versus sort of lumbar or nerve root monitoring.
Yeah, and maybe what we can do here is you could perhaps walk us through a specific case without obviously any identifying details, but a specific case maybe where a change in monitoring signals directly influence a decision you made, and maybe what did that real-time feedback change about how you proceeded? I think that would just be useful to have a specific use case for folks watching.
Yeah, I think a specific use case, I think sort of higher risk cases are severe deformity or vertebral column resection cases, where you have a severe angular deformity, many times associated with sicker spinal cords. I think we've gone from previously not being able to do such big corrections and use as much instrumentation as that has evolved. The use of monitoring has really allowed us to do more and more real-time monitoring of the spinal cord. For example, vertebral column resection, many times you present with a sick spinal cord or a pre-existing neurologic deficit and a severe deformity. And so in order to obtain improved correction of your spine, you have to do a 3-column spinal osteotomy and work around the spinal cord. Many times your risk of a monitoring change in those cases is 100%. Some of those are based on the amount of Cobb angulation you have, some amounts on your sagittal plane deformity, pre-existing neurologic deficit, and your focal deformity as well. And so when you're resecting those, you're sort of working around the entire spinal cord. And the most sensitive indicator of a spinal cord function loss is your motor evoked potentials. That's where you're going to see a great loss. So I think that's the advantage of intraoperative neuromonitoring, is you can have a change both during your decompression or your osteotomy, or once you close your osteotomy and you correct the deformity. If you're measuring your motor evoked potentials and sensory evoked potentials, you have a greater understanding of why you're having a change and what changes you need to do to get back to a baseline monitoring that you were before your correction. If you weren't running monitoring, you'd have no idea. If the patient wakes up with a deficit, you really don't know how to do a correction at that time. So real-time monitoring of spinal cord function is really the advantage of intraoperative neuromonitoring.
Yeah, I appreciate you walking us through those details there. Mitali, would love to come to you now and just get your take in terms of what this kind of looks like from your side of things, from the monitoring team side of things. What are you watching for in instances like that, or other sort of scenarios that we could talk through?
Yes, in my experience, I have seen that during correction, we really closely watch the blood pressure for kids, and we always catch a little bit decrease or decreases in signals during correction, especially if the blood pressure is low. They're quite sensitive to the blood pressure points, as well as they're quite sensitive to anesthetic changes too. So we actually need a little bit of experience here to figure out whether this is because of the correction, the changes, or because of blood pressure, or because of anesthetic changes. So we are always actively checking for everything in these cases. It's not like, okay, we ran something and it's there, okay, let's go ahead. It's more of an active monitoring role for deformity correction, always. And we are continuously running SSCPs. We run motors consistently every 15 minutes or so. And during correction, it's basically every 5 to 10 minutes that we run motors, and we make sure we have everything. And my team and us, we don't skimp on any coverage. We cover every muscle possible for correction in the lower extremities. I think these are a few changes that we do. For kids, we closely watch all these factors.
Excellent. And Dr. Dory, I have a question for you, but I want to get on something else with Natalia and Dr. Hedequest quickly here. Can you talk a little bit more about what communication between your two teams looks like here. Matali, maybe from your point of view, can you share some details about what that's like?
Yes, absolutely. We always communicate anything that goes on in the OR to our reading neurologist. We'll tell them that we are watching this. I've seen a little bit of change and I'm watching this and I'm talking to anesthesia, or I'm telling the surgeon that, hey, I'm going to go check the positioning of the leg. So everything that we do, we communicate with our reading neurologist. It's more active during the critical period of the surgery, which is correction time or osteotomies or decompression time. A lot more communication with the whole team, basically, not only just our neurologist or the surgeon, with the anesthesiologist, even with our circulator. If I need help with positioning the arm or the leg, or if the leg has slipped off, so everything is uh, very active during that period.
Constant, immediate communication. Dr. Hedquist, what does this look like does that line up with your experience? I'm sure it does, but what else can you share from your point of view?
Yeah, I think, there's communication with the monitoring techs, and I think there's communication with the anesthesia and the whole team. Remember, it's not just a monitoring change. You have to communicate what your monitoring change is, right? So the two major deficits you're going to see is either a perfusion-based monitoring change or mechanical-based monitoring change. And that's why it's good to really understand that. So if you have a pure motor monitoring changes to both legs, you're thinking about a perfusion-based question. So that's why you want to know, is this a motor change or is it a sensory change? If you have a mixed change on one side, that makes you think you have more of a mechanical change rather than a perfusion-based change. And so intraoperatively, we're going to run our motors about every 15 minutes. If you're at a higher risk portion of the case, you're going to increase the amount of monitoring you're going to run. So it's going to be a feedback back to Matali and the team. If you have a perfusion-based problem you're worried about, such as a pure motor-based change in a scoliosis case, then you're going to talk to Matali about it. She's going to say it's a pure motor-based. You're going to talk to anesthesia about. Then we want to increase the perfusion, right? We want to increase the map. We want to think about our blood loss, do things like that. Do we put a rod in? Did we stretch the cord? Does the rod have to come out? Or if you've had a mechanical change, you have a unilateral loss of motor and sensory, you're worried that you might have had a mechanical push on the cord or a direct injury to the cord. So your response to that's been a little bit different. So it's not just one monitoring change fits all. It's sort of a clear understanding of what your monitoring change is, because that really dictates the anatomy that you're dealing with and whether it's a perfusion problem or it's a mechanical problem, or the third thing, it can be an anesthetic problem. So those are the three things that the communication helps really understanding what that is, and then knowing what that understanding is going to say what your checklist is going to be.
Yeah, that communication is going to help you find the appropriate clinical next steps, right?
Absolutely.
Yeah. Dr. Doria, I want to come to you now and get your take in terms of how specialty care really gets its teams ready for this type of scenario, for pediatric cases specifically, to be that communicative, to be ready for these types of cases.
Yeah, good question. We have a robust training program. All of our folks in the OR have extensive training. We take pride in that they're all CNM certified, which is basically certification in neurophysiologic intraoperative monitoring. This is awarded by ABRET. It's highly, highly valued, and we take a lot of pride in that for all of our folks in the OR. But more importantly than that, we have a really, really strong med ed team, and these folks are constantly having their competencies evaluated, reevaluated, reassessed. We really want to make sure that we have the right folks for the right cases. We don't want to mix and match that. So we take a lot of pride in doing that.
Yeah, and can you unpack that even further in terms of getting the right folks on the right cases? What details can you share in terms of like what competencies you're looking for there, maybe even personality traits? I'm curious to hear.
Well, I'd like to think everyone has a great personality, but when we think about what we factor into it and what we look at, we want to see how many cases they've done. What we look at the core level is what age groups of cases have they done? How many have they done? We look at the procedures. If it's a curvature correction, how many of these cases have they done? How many complex cases have they done? We look at each and every one of these mapping cases. How many have they done? We even break it down to the modalities. What modalities are going to be offered for the case? Are they MEPs? Are there going to be SSEPs, sensory, motor? What's going to be run? How competent are they with this? Hearing, if they're doing bears, if they're doing cortical mapping, we want to make sure that all these folks have significant experience in each of these domains before we put them on a case alone. Prior to that, we do have them buddy up with other folks, clinical managers, area managers, to get more experience in these cases if needed. We do want to make sure that we have the appropriate competencies for these cases.
A thorough process of sort of vetting the experience of folks before you push them into any sort of scenario, correct?
Absolutely, yeah.
Excellent. Well, let's shift now to get some more of the adult perspective here. Dr. Zaidi, coming to you now. You work on some of the most complex cases in adult spine. Which of those cases do you find in terms of whether it's, deformity correction, tumor resection, complex revisions, where do you find this monitoring to be most indispensable for and why?
I mean, I couldn't have said it any better what Dr. Hedquist was talking about earlier, mechanical trauma versus a perfusion-based, change in neuromonitoring. But talking about, where I have found neuromonitoring to be the most helpful in the adult world is, typically it's a thoracolumbar deformity, right? But these are elderly patients with disease throughout their spine, right? It's not like a kid who has a thoracolumbar deformity, but no cervical or distal lumbar disease, right? These patients have terrible looking degenerative changes throughout their spine. So, I use it at almost every stage of the case, and I can't think of one stage that I find more important than the last, right? So even just the positioning, someone who has cervical spondylosis has a spinal cord that looks not so great in the cervical spine, but not bad enough to justify surgery. And you're wanting to treat the thoracolumbar disease, just positioning them on the operating room table alone, neuromonitoring is incredibly helpful. I always think of our excellent neuromonitoring folk as like the, last line of defense, right? We as surgeons, we start to focus on the technical nuances. The circulator's worried about finding whatever in the room. The anesthesiologist is worried about the A-line not working. But our neuromonitoring folks are the ones who are telling us how the patient is actually doing, right? If an arm falls off the table while everybody else is doing their own individual, very siloed thing, you will tell us like the arm is not in a good position. And that's just gives you the comfort as a surgeon that, okay, there is somebody who is kind of bringing this all together to make sure the patient is safe. So yeah, thinking about positioning or positioning related issues. Also, hardware placement. When I was first starting off, training 15, 18 years ago, just putting in instrumentation was a very big deal. Now, with the technology that we have, not just intraoperative navigation, but neuromonitoring to confirm screw placement, I can't even think of the last time that I personally saw a malpositioned screw because either the navigation system will tell you something's off, but more importantly, even after instrumentation, we stimulate each and every single one of these screws with, very complicated trajectories. And if there's a malpositioning, we'll know it before we ever leave the patient, leave the operating room. And then from, adult perspective, things like intradural pathology, meningiomas or intramedullary pathology. I mean, it is incredibly important to give you the confidence as a surgeon that you can push the limits further and further, right? I think 15, 20 years ago, without good neuromonitoring techniques, we would stop short, right? Because we wouldn't want to hurt the patient. But with how sensitive this technology is, we can really push the limits of what is possible and safe because neuromonitoring gives us the confidence to be able to go a little bit further from a technical surgical standpoint. So
you laid out a lot of great areas where this technology is essential. Positioning, instrumentation, putting in instrumentation. Is there anything else you would add to the list here before I move in and get Matt's perspective? Would love to just get anything else out there where you think, whether it's a particular maneuver or phase of a procedure, where this technology is just absolutely crucial.
Yeah, I mean, if you put a gun in my head and asked me to get rid of neuromonitoring for one particular stage of surgery, I don't know if I could choose one particular stage because each stage is so critical. Like, I mean, even if you think about, after all the hardware is in, after the instrumentation, classically in the adult and pediatric world, the neuromonitoring doesn't change right away. It changes in a delayed fashion. So even when you're closing, I mean, neuromonitoring is still crucial and important. So I can't think of a stage in the case where I would, defer neuromonitoring.
Yeah, and fortunately for you, Dr. Zaidi, I'm not going to do that to you. I'm not going to make you
Yeah, please
have to
don't take
make
away
that
my
choice. Yes,
neuromonitoring.
I will. Matt, what does this look like from your perspective? Just share I guess maybe what it's like collaborating on these cases and where you find the technology to be absolutely most critical.
So the biggest thing in these cases, I believe, is communication, like Matali and Dr. Hedquist said. We're part of the team, and having the trust and understanding of both what the surgeon is doing and the neurophysiology teams are doing. We need to collaborate together to make sure we all have the same primary goal, the best patient outcome that's possible. And having the trust between the surgeon and the neurophysiology team, along with the rest of the team, the anesthesiologist, the nursing staff, when things become critical and we do have these alerts and changes, reacting quickly and communicating those changes to the surgeon in real time. You have a limited amount of time to make a change where it becomes a non-permanent change. So really just having a team that have a lot of trust in is incredibly important. Um, and those moments where instead of, oh, is this a real change? Is it not? Working with Dr. Zaidi and Dr. Hedquist, they have a lot of trust in us. And when we tell them, oh, this is what we're seeing, they immediately look to us and say, okay, well, what do we need to do here? Do we need to talk to anesthesia? Do I need to take the rod out? Do I need to reposition the neck? And having those conversations in real time always lead to a better patient outcome.
Yeah, and Matt, can you the comments about trust are really interesting. You've got to have that to have an effective collaboration, effective partnership. Could you walk us through potentially a scenario or paint a picture for folks out there when this collaboration is really humming, when things are going really well? What does that look like from your perspective, Matt?
So in the real time, you're working with the surgeon. The surgeon is telling you the steps of the procedure. We're constantly communicating back to them what we are seeing. Everything is stable. We're communicating with the anesthesia team, so we know where the levels are at. The surgeon also is communicating with the anesthesia team, and so they know where everything is at in that moment. So even when everything is going perfectly, we have a constant level of communication so that if something were to happen, we know where to look first.
Excellent. Dr. Zaidi, from your perspective as well, does what Matt shared along the lines of trust and the constant communication that has sort of been a recurring theme in our conversation today, does that align with your experience? Anything to add in terms of what this really looks like when the collaboration is really working at top level?
Yeah, I mean, what I would say is, that trust is so critical and that experience is so critical because the neuromonitoring team has to know what stage the surgery is in, right? Sometimes we as surgeons, we get focused on our technical, what we're doing from a technical standpoint. It's really important for the neuromonitoring team to be able to know what stage that you're at, right? And Yeah, because there's certain parts of the case where you have to increase the frequency of monitoring. And like Dr. Hedquist said, I mean, it's really important for there to be a constant open line of communication between the surgeon and the neuromonitoring team to work together to remind one another of, when's a good time to get a motor evoked potential. If it's been, for us, when we're doing the fun part of the surgery, we could spend 2 hours, and for us, it feels like 2 minutes, right? So it's really important for the neuromonitoring team and their experience in knowing what stage the surgeon's at to constantly remind us when to get motor evoked potentials um, and then also the experience matters where there's so much information that we're flooded with as surgeons, right? Like it's not like we're getting raw data from our neuromonitoring team. This is digested information. And so when it's brought to our attention, it's information that is real because there is a phenomenon of decision fatigue for physicians, right? Like if you're constantly being flooded with raw information, yeah, then you can't do a good enough job because your mind is elsewhere, and you can't do a good enough job as a surgeon because your mind is elsewhere. So you really need a team that's there helping you and digesting this information and processing it because it's a lot to take in as just one physician, right? So.
Yeah, a lot to process. You're relying on each other to both be fully informed. Dr. Doria, I would love to hear from you on this in terms of your perspective as the medical director with specialty care. How do you think about trust specifically as that has sort of emerged here as a core theme?
Yeah, trust without a doubt. It's so important, and I think this is based on the team. And when we think about teams, you think about specialty care. Specialty care is a large company. There's a lot of employees. But another thing that we pride ourselves on is we are broken into regions and there's continuity. Dr. Hedequist, Dr. Zaidi, they want to see the same folks in the OR. They don't want to see somebody they haven't met before, somebody they haven't worked with before. That makes the case more difficult and you have to restart that trust building. So we do try to keep the same folks, the same teams in the same region, and same thing with the oversight. We have the same oversight physicians on the other end that are monitoring the cases with our folks in the OR. So they're always paired with the same couple of folks. Trust is very, very important. It's all about the communication and the trust, without a doubt.
Yeah, and another follow up for you there, because some of this is very challenging work. And even when you have strong trust on teams and strong alignment, making the best choices available to you, you're going to have challenges. I guess, how do you think about moving through, from your perspective, moving through those challenges and continuing to make sure there's that baseline of trust established? How do you think about setting up your teams to be able to do that?
So open and honest communication. A lot of times, a lot of this is bi-directional online. Telephone numbers are always available. If anyone needs to chat about these things, we encourage folks, get on the call into the OR, have a conversation as a group. If there's anything that needs to be discussed in further detail. Also outside the cases, we try to get together regionally outside with our groups just to get together to commingle outside of work. This way we're putting faces to the names and we know the folks that we're working with. It gives an extra layer of personalization to these cases and to the work environment.
Yeah, you get to know folks. It's easier to communicate, I imagine, as well. There's that level of comfortability.
Exactly.
Let's pull back, and I want to come to Dr. Hedequist. We'll come to you first, but Dr. Zaidi, I want to hear from you on this as well. This is really, you both sort of alluded to or mentioned specifically how this has changed the work you're doing today, this technology. Stepping back, I guess, how is this technology, this ability monitoring this data, this information you're getting, your overall confidence, I guess, when you're going into a particularly complex case, and maybe how has it even shifted your plan or what you're willing to do surgically? Dr. Hedequist, can we begin with you?
Yeah, I think it's you have much more confidence than we used to have than when we just monitored sensory evoked potentials. So now when you're doing motor evoked potentials, I think that's a much more sensitive to real-time injury to the spinal cord. So the ability to do more complex osteotomies or vertebral column resections or bigger corrections in a safe manner is higher. I think, and that goes a little bit back to, I think, as a surgeon, having a really good understanding of what you're monitoring, what function of the cord you're monitoring, and what the different potentials mean to you. The monitoring tech is your team, and they're going to know probably as much or more than you do. But for younger surgeons going into monitoring, it's not just potentials. It's like what potentials and what do they mean at each part of the case. And then having the trust to talk to your sort of monitoring tech, I think is super important. And if something's really complex, the monitoring folks, Matt and Matali, are backed up by Dr. Dorian or the neurologist. So it's a pretty big team approach. So in higher risk cases, I think you have a much more trust in trying to meet your goal, knowing that your monitoring is pretty reliable. And I will say one thing we didn't talk about a little bit for quality control that Dr. Dorian talked about a little bit is, we get monthly and yearly reports from the company as far as monitoring our cases throughout. So we have a quality control if you're a surgeon leader in your division to sort of see what exactly is happening on a daily basis throughout the year with regard to monitoring changes in quality control. So that's just another layer of trust that we know we're getting excellent monitoring.
Excellent monitoring, and that sort of you're able to really look at a big swath of information and make some
Yeah.
determinations, right?
Yeah, and the other thing is, back to Dr. Dorian again, um, we talk about teams, right? There's no culture of safety that exists that isn't team based, right? Whether it's in flight or whether it's spine surgery or any high complexity thing, it's always a team based culture which is successful. So, uh, the monitoring techs that are fresher or newer, they're being sent out with either Matt or Matali for the first batch of cases. So even if we see a sort of a fresh face, it's always backed up with someone that's got more experience until they've been in the system enough to sort of really build our trust.
Excellent. Dr. Zaidi, coming to you now, in terms of when you're about to maybe take on a particularly complex case, how has this partnership, this ability, this technology shaped your confidence? How has it changed?
Yeah, I mean, I just echo what Dr. Hedquist and Dr. Doria were saying. When you're taking on a particularly difficult case, you have to have trust that the entire team is on the same page. And when you have that ability to know that you have good monitoring, it allows you to push the envelope just a little bit further each time, right? So I think about, like, for example, a thoracic calcified disc herniation, which was an incredibly high anxiety provoking case. Um, and sometimes you don't know how much of a calcified disc you can take out because you don't know how much the spinal cord can tolerate, right? But with neuromonitoring, and I've seen this evolve over the last like decade and a half or so, with neuromonitoring, the better this technology and the more reliable this technology, on top of having a team that you can trust and work closely together with. For me personally, I can tell you I push the limits further and further. I don't, the way I did them 10, 15 years ago is probably different than the way I do them now because I have confidence in the team and I have confidence knowing that the neuro monitoring is reliable. And so it allows you to take a little bit more pressure off the spinal cord, do the surgery a little bit safer. Um, so yeah, I mean, that's all I have to add.
Appreciate it. And maybe now what we'll do before we get into some audience questions, and folks out there, as a reminder, you can put those questions into that Q&A box you see on your screen. I would just love to hear before we do that. A lot has based on the comments, this conversation, and Dr. Zaidi, what you just said in terms of this is very different. How you do things is very different than it was 10 years ago, and it's going to change more in the next 5 to 10 years. So I would love to get some forward-looking commentary around what excites you about where this neuromonitoring technology can go in the next 5 to 10 years. What really gets you excited, Dr. Zaidi?
I'd be excited to see how AI is going to change all this. If you ask me on the spot, I don't know how it's going to affect neuromonitoring, but I am excited to see whether with AI you'll be able to pick up information, whether it's vascular issues with cord perfusion, or whether it's mechanical irritation of the spinal cord nerve roots, whether AI is going to pick up on this information even sooner than our text, right? So it gives us a initial stage warning, then second stage before an irreversible injury. So I'm kind of curious to see, how artificial intelligence is going to improve patient care down the road.
Yeah, it's really fascinating to see what's going to come there. And also, I'm kind of struck that we've just now gotten the AI's just now been brought up. I think in every conversation you have nowadays, it comes up a lot sooner. So, Dr. Zaidi, appreciate those comments. Matt, would love to hear just from your perspective what excites you when you think the next 5, 10 years.
Next five, I mean, it's so interesting that you said AI. It's one thing that it's always so interesting to hear about the incorporation of AI into neuromonitoring. And I know in the next 5, 10 years there is going to be great advancements. But the one thing that I do always want to say is it's so important to have a person in the room to convey that information, and to look at intraoperative neuromonitoring is a lot more than just staring at a screen and reading signals. It's incorporating everything that is going on in the room, everything that is going on with the surgeon, and making those best game time the decisions in real time. I think that AI is going to be an amazing tool that can really drive the quality of monitoring. But I think that that's where what it should be is a tool to improve our monitoring as opposed to a replacement of the neurophysiologist in the room.
Yeah, you need that someone to understand the human context of what it's like to be in that room to make those decisions. And the phrase we hear all the time when AI comes up is human in the loop, right? Somebody to be able to make those calls, call those plays, even with the amazing technology. Matt, appreciate those comments. Mitali, would love to hear from you.
Well, I think Matt has summed it all up. Definitely, a human factor is very important in the field of neurophysiology, intraoperative neurophysiology. Maybe in like very simple cases, there is a chance of AI being easy. It is easier for AI to analyze, but it's not just the data that we're analyzing. We're analyzing so many factors, as Matt said. But where our field is going, I think our field is progressing really, really fast, and we are developing new modalities every year. In every conference, I see new things coming up, modalities being experimented, being added, so that there are different ways to monitor different structures of the nervous system. So I think it's a very exciting time to be in our field. And Boston team is quite advanced, so we always try to incorporate as much of it as possible in every which way. I suppose, just an example, although it's not something new, but it has been in the field for a while. When you do navigation, you don't want the patient to move, and transcranial motors cause the patient to move. But now what we do is during that time, as we are not monitoring the spinal cord motor function, we do H reflexes, which are very quick, just reflex responses, which we get without any patient movement. And Dr. Hedquist doesn't even feel the patient move or do anything. But so even though during the navigation time we are not running motors, we still are monitoring the spinal cord. So there is different modalities that we choose to do in place of something else. There's always a backup in our field. So I think the advances that are going in the field is very, very exciting right now.
Yeah, Mitali, thank you for offering those details. Dr. Hedquist, same question to you. What would you like to emphasize in terms of where you find excitement next 5 to 10 years?
I think for machine learning and AI, there's already been some stuff done in the pediatric space and adult space for deformity on using machine learning to sort of predict your risk of a neuromonitoring deficit. So there's always been some papers out already that says if you have these risk factors in this score, your risk of a monitoring change can be 0. It can also be 100%. So knowing that as a team base, you can have that discussion before the before the case starts saying, hey, I've done a risk analysis, and it's going to be about 100% we're going to lose our monitoring. So let's develop a plan, or let's talk about things before in your sort of pre-surgery checklist. And some other things I've seen a little bit AI is some of maybe just the computer may be able to one day recognize things a little bit earlier than the human can recognize things. So those real sensitive data changes that the tech can't see, the computer might be able to register those, 5, 10, 15 minutes before. So those critical times where you're just getting a little bit of perfusion deficit that the Metallic can't see on the screen, that I don't notice, but the computer might be able to see subtle signals based on thousands of data points just to raise a level of alertness. So I think that is sort of, at least in modern AI, that's where we're at right now.
Dr. Hedquist, thank you so much. Dr. Doria, I want to give you a chance to weigh in here too before we grab some audience questions.
No, absolutely. I mean, I think it's biasly, I think it's a very, very exciting field. I think, the possibilities of more modalities, more multimodality monitoring is becoming more and more common. I would say year over year, we see a constant growth in cases. So I think we actually need to continue training folks to keep up with the demand of the cases. As we mentioned, there's so much movement behind AI, not just in intraoperative monitoring, but everywhere. There's a lot of movement there. And I do agree. I think that things like filtering noise, improving signal quality, and detecting those subtle changes. If you have a very, very subtle change or a very subtle trend, I do think it could pick it up quicker, and maybe help us go from a reactive to more of a predictive model. With that, we have to keep in mind how do we keep it in check from false positives? Because very, very sensitive changes, we don't want to get alarm fatigue. So I think it's a very, very exciting time, and I think it's something that will definitely augment the quality of care that we could deliver. So it's exciting.
Yeah, truly a lot to be excited about, and a lot for us to watch here in the upcoming years. It's been a wonderful conversation. Let's move now and take some audience questions. We've had some good ones come in already. As a reminder, folks, you can get those over to us by putting them in that Q&A box you see on your screen. The first question we'll grab here is the attendee asks, what should surgeons and hospital leaders look for with evaluating an IONM partner? What are the red flags that a program may not be meeting the standard of care? Dr. Zaidi or Dr. Hedquist, maybe we can begin with you on this one. Dr. Zaidi, do you want to weigh in here?
I don't know if I'm an expert in defining standard of care for intraoperative neuromonitoring, but I think just reliability, right? So this relationship, it's like a marriage. It's always there, whether your wife's there or not. It's always a marriage, right? So if a patient is coming in the middle of the night, or you are, you want that partner that you're with who is going to be there for you 24/7. So I don't know if I can define standard of care, but you need somebody who you can trust is going to be there anytime that you need them there for, improving patient care. So I don't know if I've answered that question correctly, but I'd say just reliability. I mean, that's so critical.
Reliability, and then coming back to sort of the broader theme here, which is whether long-term partnership communication or just in the OR, like that consistent communication. Dr. Hedquist, anything you'd add here?
No, I'd agree with that. I think, and the only other thing I'd add is sort of a reporting system for the monitoring company, sort of the reports that the techs give after each case, which go on the chart, and then the sort of overall quarterly or yearly report you're getting. So as a quality control, the institution, or in this case, the attending surgeon, has a pretty good idea of the trend on how things are going with communication and cases and expected outcomes.
Yeah, excellent. Dr. Doria, I think it would be great to get your perspective here too. Thinking from what you know, assuming the persona of a hospital leader, what would you be looking for? What are the watch outs folks out there should be aware of?
Yeah, I agree both with Dr. Zaidi and Dr. Hedquist. To Dr. Zaidi's point, we need to be consistent, and we need to be reliable. When we're setting up to do a case in the OR, we can't let our surgical teams down. We can't let the patients down. We need that reliability. To Dr. Hedquist's point, we need reporting metrics. We need to get those interp reports into the chart timely, but also those quarterly quality things. These are things that we look at. We're constantly evaluating what are the technical confounds, what are the anesthetic confounds. Do you have a change during the case? And I think this is important. If you have a change during the case, what happened? Was that change resolved? Was it fully resolved, partially resolved, no resolution? And then, of course, what is the new onset deficit rate at that hospital or within that group? And these are things that we report out, and we look at these internally. We look at them at a team by team basis, but we also send them and share them to our hospital partners to say, where does our group sit in relation to the national average? And I think these are very, very important things that the teams do need to see.
Excellent. Appreciate that, Dr. Doria. Let's move to another audience question, which gets to signal changes during the procedure. The attendee asks, when monitoring signals change during a procedure, what is the decision-making process? How quickly do you act? What's the communication protocol? And how do you distinguish a true signal from artifact? Matt or Mitali, would either of you want to weigh in here?
Sure, absolutely. When we first see a change in signal, the first thing we do is we want to make sure it is a repetitive change, it's not a fluke. So we repeat the signals and see that it is still a change. And then first thing we see is blood pressure goes, and if anesthesia has pushed something. And after we check those two things, we check all our, if technically everything is good. The first thing is basically technically everything is good. Then we check the blood pressure, then we check the anesthesia, and then we tell the surgeon that, hey, we have changes that we cannot attribute to either anesthetic or blood pressure or technicalities. So there's something that we need to do. So we always follow up algorithm, check all the technicalities, check then check the physiology, then check the stage of the surgery, like what stage were we when we had these changes, and we let the surgeon know and alert them, like if we can backtrack our steps. And once we have a change, we always run our signals more frequently so that we can catch a trend of signals coming back or improvement, and we let them know right away if there is improvement, and even a little bit improvement, and then the progressive improvements. So we are highly in an alert state at that point.
Thank you, Mitali. Matt, what would you add?
I would. I mean, that was great. I mean, we were always going through an algorithm of what to look for to determine if a change is real or not. Well, if it is due to a physiological reason or if it's neurological. And the one thing that we always make sure to do is in that situation, as soon as we see that abnormal signal, let the surgeon know, and then go through those that checklist very quickly and make sure that we're checking everything, communicating with the surgeon, and then so they're aware of everything that we're doing and potentially not continuing on and doing a surgical maneuver that could make things worse at that time while we do all of these troubleshooting steps. But then just an open line of communication to make sure everyone is on the same page.
Excellent. Thank you, Matt. Thank you, Mitali. Dr. Doria, anything to add here before we grab perhaps one more question before we sign off?
Totally agree. I think both Mitali and Matt really spot on with that. I think some of the biggest things that we do is communication. If we see this change, we have to communicate it. We're not sure the significance yet. However, we've seen this change. We're going to continue to troubleshoot. We'll keep you updated. Troubleshooting is very important. Is this a technical issue? Is it an anesthetic issue? Is it blood pressure related? All these things, we go through our checklist. Is it positioning? Did the padding fall out from under the arm and now there's compression there? So all these things we're looking through and we're going through them in a stepwise fashion. One additional aspect that we didn't talk about, and I think another thing that we pride ourselves, We have a really, really strong clinical support team as well. It's a dedicated clinical support team that when these tricky cases come up and something goes wrong, we do have a third set of eyes that's able to get on, help troubleshoot the equipment, and some of these signals, and even optimize signals at baseline. If we're having difficulty obtaining real good baselines, they will also get on the case and help optimize baseline. So that's kind of a third set of eyes that we have.
Excellent. Thank you, Dr. Doria. Let's move now to the final audience question we'll take before we sign off, which the attendee writes, there's growing evidence linking robust IONM programs to improve patient safety outcomes. How do you think about measuring and communicating that impact to hospital administration, especially when the value shows up as a complication that didn't happen? Dr. Hedquist, do you maybe want to grab this one for us?
Yeah, I mean, I just think it's become such a standard of care that it shouldn't even be a discussion point with hospital administrators anymore. It's very clear in pediatric deformity, adult deformity, and spine surgery in general. Intraoperative neuromonitoring, whether it's motor evoked potentials, sensory evoked potentials, triggered EMGs, D-wave monitoring, they've all been shown to be part of the neuroprotection of your patient. And there's so much literature now that I don't think it shouldn't be that hard to go to a hospital administrator and say that. It's a pretty non-defensible not to use it.
Dr. Zaidi, I'm sure you agree, but any thoughts here?
Yeah, I mean, it's easy for me. If I was getting spine surgery on myself, I would definitely want neuromonitoring so that, it has helped us more than it has confused us in the operating room. I mean, by orders of magnitude. So I personally would say that it's indefensible not to have neuromonitoring for complicated cases.
And Dr. Doria, maybe final thoughts here from you, just building on what you've heard from Dr. Zaidi and Dr. Hedquist in terms of answering this attendee question.
Yeah, absolutely. I think, at this point, it would be more negligence not to monitor the case with monitoring. I think that when cases are left unmonitored, you really can't determine the risk of injury during the procedure. So you have less opportunities to prevent or reverse any potential undetected injury. I think that's what you lose. You lose that insight.
Well, it's been a wonderful conversation. Attendees appreciate the engagement and the questions. If we weren't able to get to your question, someone will be following up with you after our webinar wraps here in just a moment. But Dr. Zaidi, Dr. Hedquist, Matt, Mitali, Dr. Doria, truly appreciate you all coming together to have this conversation with me. It was a pleasure. To attendees, thank you for making time to view this webinar, and we hope you have a wonderful rest of your day, and we hope to see you at future webinars. Thank you so much, everyone.
Thank you very much.
Thanks, everyone.